First of all, thank you very much for accepting this invitation to give us a presentation, a webinar, and obviously much obliged to have all the participants sort of enter in to join us and hear you speak. A bit about Nick. Nick trained at Guy's Hospital in London, initially going into general dental practice in North London. He then moved to Manchester to be a senior house officer at the Manchester Royal Infirmary, taking an academic route. He spent 5 further years in Manchester as a lecturer in restorative dentistry. He returned to New Zealand in 1987 to be a lecturer position at Otago, and completed a London PhD as an external student in 2005. Nick has published 120 papers and 78 abstracts in peer-reviewed journals, and has chapters in Ingle and Endodontics, Parties Endodontics in Clinical Practice, Contemporary Restoration of Endodontically Treated Teeth, Mineral Trioxide Aggregate, and Pathways to the Pulp. He has contributed a chapter to a new textbook, Endodontic Materials in Clinical Practice, due in the next few months. In 2016, he was awarded the Alan Docking International Association for Dental Research Science Award for his outstanding scientific achievements in the field of dental research. Retiring last year, Nick retains his association with the university as an honorary professor and is the editor of the New Zealand Dental Journal. So over to you, Nick. One more thing, just housekeeping for today's presentation. If you could all please mute your audio such that during the presentation there's no interference. Also, if you have any questions or remarks or comments, there's a chat box on the bottom of your screen, I suppose, which you can then add any comments there for me to look at and then attend to. At the end of the presentation, we will be having or inviting the members of the NZSC to keep logged on. We have an AGM, and I would really appreciate if members could stay on for that AGM. So over to you, Nick. The floor is yours.
Thanks very much, Dikesh, and thanks for the committee for giving me this opportunity to talk and throw away a few ideas about apical surgery and the way I've seen it change over about a quarter of a century, really. So, my slide change isn't working. Oh dear. Now it is. Okay, can you still see the slides okay, guys?
Yes, Nick. Yep.
Yes. Okay, tell me if you can't.
Well, they're all be on mute, Nick, so.
They're all on mute. Good. Dikesh, you're allowed to speak to me.
Yeah.
Just a reminder, I mean, we're all from different aspects of dentistry. The apicectomy involves resecting part of the root end. I'm not going to talk today about flap raising at all. I'm just going to concentrate on this bit here. So surgically, we resect part of the root end. We make a nice bevel there, or hardly a bevel at all, and we place a root end filling which we'd like to be about 3 millimeters deep. So in this kind of surgery, we actually treat 6 millimeters of tooth. We take away 3 millimeters and we put a filling in 3 millimeters deep. So what about the prognosis of apical surgery? Well, it's slowly changing. We've got the microscope, which has certainly made seeing things easier. We've got ultrasonic tips to make our root end cavities, and they give us really good access. And perhaps most recently, we've got some much better root end filling materials than we used to have. But for any given case, it's really quite difficult to prove that surgery is better than non-surgical retreatment. Now, there are cases where you look at them and you know that you're only going to be able to imagine treating them surgically. But if you have precisely the same cases in front of you, it's difficult to prove that surgery is going to be better than retreatment. because there are so many factors influencing the outcome. You'd need a huge study group. You'd need lots of patients with identical medical histories, identical dental histories, just about the same tooth and just about the same problem. And you wouldn't get those people. So you'd need teeth well into the hundreds. And how would you get enough randomized controls? That's really hard. And today, of course, you'd need at least a 4-year follow-up. And 4-year follow-ups are really, really difficult to do. Even the really big studies where they pay people to come back and make the treatment free and all those sorts of things, it's impossible to get a 4-year follow-up. And if you're working in Dunedin, you'll find that a huge number of your patients are students, and of course you won't get a 4-year follow-up with them because after 3 years they've gone and disappeared. So it's very difficult to prove that one thing is better than the other. But what we can say is that the aim of surgery is really quite simple. We're trying to block the pathways from the canal out into the periapical region. And in reality, because we're often dealing with broken instruments and problems of anatomy, we're actually trying to access a system that's blocked and then block it up all over again. So we're trying to do an unblocking and then following it off with a blocking. And we resect a piece of the root end. We cut away a piece of the root end. So we're removing pathology, which is usually granulomas and cysts. We're removing broken things. We're removing infected cementum and dentine. And we're removing or managing anatomical variations. So they're going to be the deltas, the accessory canals, and the isthmuses. So you'll see that what we're doing there is remove, 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 remove. It's a little bit like location, location, location. We're trying to get rid of stuff. And there's huge amounts of evidence for removing 3 millimeters of the root end. It's not something that's been plucked out of the sky. There's big literature on 3 millimeters of root end resection going right back to 1966 with these rather old anatomical papers. So 3 millimeters is an established amount of tooth to take away. And the textbooks more or less agree. These textbooks all say 3 millimeters. Some of these are now previous editions and have been updated. This textbook says there may be situations where 3 millimeters is too shallow. This textbook, and it's just been replaced this year, came to the 3 millimeter conclusion. The undergraduate textbook, Harty's, says a depth of 2 to 4 millimeters is sufficient. And the most recent text in Ingalls issue says no more than 3 millimeters. So we've got good evidence and good academic backup for that 3 millimeters of root end removal. And the slide doesn't want to go forward. This is peculiar. Yeah, 3 millimeters. So what about the bevel? Now, this is all the way back to our friend Brian Tidmarsh and our American friend Mark Arrowsmith from the International Endodontic Journal 1989, and a very, very important paper, this one, proving that as you bevel, you open up dentinal tubules, potentially all of them infected, and you would like your root end filling to go down beyond the level of that infection. So even though that's convenient to look at and easy to do, if you have no bevel, you're not opening anywhere near so many dentinal tubules. So this was a really big, really important paper in the story of endodontic surgery, to try and cut things with no bevel. But that's really difficult to do. Now, this is a patient from the postgraduate clinics, and I supervised this little piece of surgery. We knew the tooth was hopeless and was going to go. The reason we did the surgery was to get some healing so that we could put an implant in. So the patient knew the tooth was going, so the surgery was to get some bone back apically. And if you look at that bevel up there, if you're being generous, you could say it's a 9-degree bevel. If you're not being generous, you could say it's a 16-degree bevel. So I looked into this mouth, I looked into that cavity, and I said, that looks jolly nice. And there's a big literature showing how bad we are and how misled we can be moving those bevels. We don't always. So let's have a look at some aspects of magnification. This is some work done about 8 or 9 years ago by Anna Kim. Can we see cracks and defects on the resected root faces? And this is an interesting thing to consider because if there are cracks there, then your surgery is probably going to fail. If you don't see anatomical defects, you're not going to be able to fix them. So can we see them? And the role of magnification does need some clarification. We all think that if we magnify things, it's going to be a big help. The textbooks still waver a little bit on what burr we use to resect the root end, and does the topography of the root end influence our detection of cracks during surgery. So there's some unknowns there. So Anna's objectives in her experiment was to look at different burr types and see if they influence cracks, deficiencies, and anomalies, and to look at naked eye, loops, and the dental operating microscope to see if cracks and things are there, and compare that with the gold standard, which was scanning electron microscopy. And the thing about scanning electron microscopy is once you put a specimen in the microscope, it's ruined, you can't do anything further with it. It desiccates some cracks. And so the way this experiment was conducted was that at each stage we took an impression of the root face and we made a model of it with epoxy resin. And when we set out, we were told that we'd need a special impression material and we'd need a special epoxy resin. We in fact use light-bodied crown and bridge material and standard Selleys Araldite straight from Bunnings. So we didn't take any special precautions, and we made some really, really beautiful scanning electron microscope models. So the experiment runs along with the root fill teeth, and you'll see here that 3 millimeters about has been resected. We resected them with different burrs. Now, one of them's a burr that you might expect the oral surgeons to use, and one of them's the 30-bladed tungsten carbide composite finishing burr, which is very difficult to say quickly. 30-bladed tungsten carbide composite finishing burr. And we got some amazing results. Now, here's the experiment. Myself, Tina Howland, and Lara Friedlander all looked at these resections with our naked eyes. And then 2 weeks later, we looked at the teeth all over again in a random order with loops. And then 2 weeks later, in another random order, we looked at them all with the microscope. And after each look, we took our little impressions and made epoxy replicas, and they went under the scanning electron microscope. So at no time did we damage and ruin the tooth so we couldn't take it to the next level. So there was an awful lot of looking at teeth and scoring their resected root faces. And here's some examples here. I think we can all say that that's a severely rough resected root face. This one's moderately rough. And when you look at that, the bevel angles change slightly. So you're almost seeing a crack there when you look at that. And you might record that as a crack. Up there's a beautifully smooth resection. And over here is a resection that we called a slightly rough resection. We recorded the cracks on the teeth, 48 teeth going through the experiment. We had a way of scoring the cracks and where they happen to live for each tooth. And away they went to the scanning electron microscope. And we looked at the pictures on the SEM, and this is the gold standard. And here, I think we can agree on a crack running along there at some stage in the process. And just to remind you how small these resected root ends are, there's a millimeter there. So the root isn't really much more than 2 millimeters across. So we are looking at something really tiny. and here we're looking at it at a 25 times magnification. So these are the kinds of pictures we got under the scanning electron microscope. We made a little groove in the tooth so we could orientate it as the experiment progressed, because at one stage we were resecting and at the next stage we were cutting the root end cavity. So we had to be able to find our way around the clock face all the time. And that's quite a nice rough surface of a resection. Here it is in the naked eye image, as it were. Here's one where we recorded a canal anomaly. So we thought that was a little additional part of a canal, or the canal was slightly non-circular there. But in fact, what it is, it's a little bit of GP that's been smeared as the resection has gone on. So that's an example of how you can be misled by the appearance with the naked eye. If I just move this slide on here, this tooth here really does look like it's got a crack running across there. But when you look over here, it hasn't. It's where the burr orientation has changed. It may have a crack there and it may have a crack there, but it hasn't got a crack there. And this is the kind of conundrum that this kind of work presents to you. So when we looked at it with the different optical aids, no cracks were detected with loupes and the naked eye. 13 cracks were found in 7 teeth with the scanning electron microscope. 5 cracks were seen with the microscope in 3 teeth, and 3 of those cracks were not seen with the SEM. So in other words, we're looking down the microscope saying the tooth's got a crack in it, and when we get the scanning electron microscope picture, it doesn't seem to have one. And this is the only tooth with 2 cracks that was picked up both with the operating microscope and the SEM. So amazingly, we picked up the crack there, we picked up the crack there, and it was true. But most of the times, we were recording what were in effect untruths. With this particular tooth, and you can see it's got a kind of a dish-shaped bevel on it, the operating microscope reported 2 cracks. But I don't think there's any cracks there at all. There's a little bit of a deficiency. You can see the gutta perca and the sealer there. So there's a deficiency, but there certainly isn't a crack visible on that tooth. So our conclusion, and people didn't like it, was the usefulness of the operating microscope or loupes when looking at the quality of the root end cavity or filling was rather limited. Here's the people involved. We've got 2 abstracts out of this. We have submitted this work and had it rejected. So one of my retirement honorary professor jobs is now to try and get this published, because it's quite interesting. We took it to a little bit further down the track, and we looked at a tooth with a root end cavity in it with a defect in. This is where the ultrasonic tip has skated across the resected surface as an accident by the operator. And we sent that tooth away to be filled with mineral trioxide aggregate. And when we took the picture again, you can see the MTAs made the most amazing job of filling in the defect. So it is quite exciting to see the quality that you can get with your condensation of root and filling materials. And we also use super EBA, which people nowadays probably wouldn't use, but we had very, very similar results with super EBA. What you're seeing in this picture here, of course, is the gutta perca looking at you. So we've made our root end cavity here, and there at the bottom is a little bit of GP looking at us. And that, of course, means that we're not going to get our 3 millimeters of cavity there. We're going to get it there maybe, but maybe not there. So that makes you go back and think about your resection and your depths again. This is one of my favorite slides. It's one of my favorite typos in a journal. The Gilheeney and Tyus one from 1994, they really took Brian Tidmarsh's work and they looked at the bevel angle, and they also looked at the depth of the root end cavity. But they made this superb typo here, the angel of resection. And I just die whenever I read angel of resection, because I know that when you resect a tooth, you're a jolly lucky man if you get near a 0 degree resection. Most of the time you need an angel to help you. But that's an interesting picture which relates the bevel angle to the depth of the root end filling. And that was really the follow-up to Brian Tidmarsh's work. So how deep should our root end fillings be? We want 3 millimeters into our 3 millimeter cavity. But can we achieve it? When you look at this picture that we saw before, that doesn't look to me to be 3 millimeters deep. So maybe we're not getting our 3 millimeters. So we did an experiment at the school. It was the ideal experiment, obviously. We had 180 root filled teeth, and I got them from another experiment. Nobody was going to sit down and root fill 180 extracted teeth. I resected them all at 3 millimeters, so we had nicely resected teeth. And some of the endodontists involved in this are actually watching this presentation tonight, so I have to be careful what I say. But 6 endodontists kindly helped us with this experiment. 4 up there in a place called Auckland, 2 down here in a place called Christchurch, while we stayed down here in the sunny weather in Dunedin. And we said they could have magnification if they wanted. We didn't ask them, and we didn't ask them what magnification they used, actually. We just said, do it your own way. We did ask them to put the little roots in a simulated bony crypt so that they had some simulation of working in that confined space. And what we did to try and keep things standardized, we sent the same ultrasonic machine to all of them by courier. So the ultrasonic machine went by courier to Auckland again, to Christchurch. It went up and down the country quite a bit. And we gave each of our researchers a new 3 millimeter tip for every 10 teeth. So we didn't give them an instrument that was blunt, or we hope not. And we knew that this tip should give us a 3 millimeter cavity. So we are expecting our endodontists to send us back a large number of teeth with 3 millimeter cavities. And just while we're talking about ultrasonic tips, they give us great access, but there's very little evidence of better healing compared with the old-fashioned cavities we made in the mid-1980s with tiny burrs. So back at the turning point in the mid-80s, we were using miniature handpieces with miniature burrs. Then we moved over to ultrasonic tips, but nobody's been able to prove that we get better healing with our neater cavities. So the endodontist did us proud. They sent back the teeth with the root end cavities cut. Here's an example. Looks a very tidy piece of work. I filled the cavities with MTA and I radiographed them. Now, I wish I'd filled the cavities with amalgam, because then I could see my fillings better. But if I'd filled the cavities with amalgam, a journal would say nobody fills their teeth with amalgam, so we're not going to publish your work. So I filled all of those little cavities with our MTA and took digital radiographs of them. And you can see the little cavity there. You can't see it there because, of course, the MTA has got more or less the same radio opacity as GP. That's what it's meant to do. But I can't measure there the depth of that root end filling or cavity. I can there, and I can there. So away went the teeth, 180 teeth, 4 pictures I could do nothing with. Whoops again. I couldn't discern the depth for 32 teeth because MTA looks like GP, and it's meant to. So I could measure 144 root end fillings, which is a good number. 17 of them had a void, a gap between the GP, so I didn't know if they'd been adequately filled. So those ones I rejected. And the mean depth was 1.93 millimeters, and the range of cavity depths was 1.06 to 2.88. So not one of those fillings reached 3 millimeters. So the endodontists are given a 3 millimeter cutting tip, and none of them managed to do a filling that's 3 millimeters deep, even under ideal conditions. And looking a little bit further towards that, there were very significant differences between some of the endodontists. So what you've got here is everybody being given a knife and fork that's the same in a restaurant, and everybody eating in a slightly different way. Who knows what their conditions were in their surgeries on the day they did the job. But it's a human performance thing. So it's a little bit of a worry that we make a recommendation for a cavity of a certain depth and we don't achieve it. And everybody does something just a little bit different in a very, very ideal environment. No blood, no mess, nice sharp instruments. And then when you talk about the cavity, there's going to be a smear layer. What do we do with it? Well, we've done some work at the school where we try to lase the inside of the cavity. We've put chlorhexidine in the inside of the cavity. We're not sure about that. And of course, we don't know if that smear layer is infected. So we might cut a nice cavity dimensionally and be happy with it, but we don't really know much about what's going on inside the cavity walls. And then having talked about cracks, do we make cracks during our surgical treatment? And here's a paper which showed that if they resected a root and found a defect on that resected surface and then cut their root end cavity, there was a more than 50% chance that they'd generate a big crack. So if there's something wrong at that root end and you then make the root end cavity, you're going to make it worse. And that takes us back to what I've just said about, can you see if there's a crack or not? And all of those disagreements that we had, even using the microscope, about cracks. So probably things aren't anywhere near as good at the resected root tip as we'd actually like. And that leads us on to things like this, which is a second surgery that we did at the school. The tooth's already been resected. We raised the flap and oh my goodness, there's a vertical root fracture going well down half the front of the tooth. Now, today, of course, we'd avoid that by having a cone beam image. And before we started doing the surgery, we'd be able to say to the patient, you have no labial bone. And we might even be able to say there's a crack there. So this takes us back to the never make promises when you're doing surgery, because there may well be something that you'll find once you've got the flap raised. Talk about materials. Dental materials, especially for this job, they're a giant simultaneous compromise. You want something that's chemically good, you want something that's physically good, biologically good, economical, which of course is a problem in dentistry, and practical. And that's a ginormous ask of any of our materials for any of our tasks. But it's a pretty big ask for a root end filling material, because we need to work in very adverse conditions. We need to adapt something down onto gutta perca. We need it to relate somehow to any remaining sealer material. And of course, we probably don't know what sealer was used to fill the root canal. We need it to behave near to exposed cut dentine, which means we need to think about smear layers and things like that. And we need something that is okay in the presence of blood, at least through part of its initial setting stage. So what do we got? Amalgam. Amalgam lasted until about 1992. The textbooks were still saying in 1992 that amalgam was about the best material we've got. And we know from some quite good studies that it's harmless to the patient. Patients do turn up nowadays and say, I'm very worried, I've got amalgam in my tooth from surgery done a while ago. We know that's actually harmless, it doesn't change blood mercury levels. But of course, now we've got the European directive and we've got environmental pollution. Amalgam went. I'm not going to talk about composites because it's a bit of a tangled web. Some people are great believers in them. And Glass ionomers, you've got the problem of the dentine bond and how long it might last. And you've got ion leaching of fluoride and whether that will last for any great length of time. And nowadays, of course, we've moved on to hydraulic silicate cements, and they really started with MTA in 1993. The first paper on MTA was the 1993 paper, so quite a long time ago. And what was MTA? Well, it's Portland cement and bismuth oxide and water. And the grey one was patented in 1993, and then the white one in 2002. And then commercially, the grey one came out in 1998. Excuse me, so it took 5 years from patenting to make a commercial product there. And then after the grey MTA, the Brazilians came in with MTA Angelus in 2001. So MTA's development took a wee while to become something commercial. So it was the first of these hydraulic silicate cements. We did some work very, very early on. This is Bayardo Martel, who's now in Brisbane, and we looked at electrical and dye leakage comparisons. And my goodness, was MTA a really good leak-proof material, which everybody knows now, and some people now would discredit this kind of leakage work anyway. We did electrical leakage as well, which was quite a complicated and good thing to do, but the MTA didn't leak any more than our control. So it's a jolly, jolly good material from a pure sealing point of view. And we know now from some really quite well established studies that it gives a better outcome at 5 years than amalgam and super EVA. So we do have some data over some years to support the use of MTA in our root end fillings. And we can go back to these old pictures now from 1993 showing MTA, and the MTA has been lost from this section. That cementum growing over the resected root end and a normal periodontal ligament. And then over here, this tooth was root end filled with amalgam. The amalgam's gone as part of the tissue processing, but you can see that there are inflammatory cells where the amalgam was, and cementum has tried to grow over the cut end of the root, but not made it. So with MTA, you in effect get two seals. You get the seal of the MTA, and then you get the biological seal of the cementum growing over the cut end in most cases. So it's really, up to a point, a miracle material. But there are no standards for testing endodontic surgical materials, which is really, really weird. I mean, if you look at endodontic materials, there's an ISO for sealers. There's nothing for hydraulic silicate cements, which have now been around for 28 years. So it's pretty amazing to think that these materials have been established and on the market, and nobody's come up with an ISO set of tests for them. If we look back at the history, the recent history, the problem with MTA, of course, was handling. When you mix it up, it's a horrible sandy material. It's got a very, very long setting time. And if we look to this slide, which is just over five years old now, you can see 5 years ago, there were 23 materials of this type on the market. And if you look at the thing here, the important thing is the working time and the setting time. So all of these materials have been developed to try and give you enough working time and to set quickly, as opposed to MTA, which was difficult to handle and had a very, very long setting time. So things have moved on hugely, but there were a lot of these materials around 5 years ago. We've got to be careful because MTA is a trade name, and I've been guilty of this a lot, saying that this is an MTA-like material, but there's no such thing as an MTA-like material. It's either MTA or it isn't MTA. And there's recently been a classification of these materials, and naturally enough, they've made MTA type 1 because it was the first one around, characterized by being a sandy material with poor handling and a setting time of at least 2 hours. So here's the classification that's out today, and you can make this slide a lot more complicated by adding in a large amount of chemical information. But if we have hydraulic silicate cements here, we can divide them into 2 families. The Portland cement family, we can put them into the calcium sulfate family, and then we can have ones that are mixed with water and ones that are not mixed with water, they're mixed with something else, or not mixed at all. And then on the right-hand side of the slide, you can see that they're divided up into types 1, 2, 3, 4, and 5. So that's really quite recent development to try and sort out what's become quite complicated in terms of chemistry and what's on the market. I'll mention biodentine here because a lot of people immediately say, why don't we use biodentine for root end surgery? These radiographs show MTA here and biodentine here, and you'll see from the radio opacity that you can hardly see the biodentine at all. So if you've got biodentine in your surgery and you think you might use it for a root end filling, my advice is don't, because if you can imagine this being surrounded by some bone, you will never ever see that root end filling. It'll just disappear into the murk. We had a case at the school with one of these vertical anatomical defects going all the way down the length of the palatal surface of a lateral incisor. The periodontist made a great big trench, filled it all with biodentine, put the flap back, and you couldn't see the biodentine at all. So from a medico-legal point of view, you couldn't actually prove that you'd been there. And so biodentine is a type 4 material. It's designed as a dentine replacement. It was never really thought of as something we might use surgically. Type 5s, if we jump straight from type 1 to type 5, these materials are specifically designed for surgery, and they're putties. And the putty's made of the cement and an additive. There won't be any water. There'll be a radio pacifier. And the common names for the type 5s are Endosequence, which is a Brasseler product that's got most of the market. Another one, Total Fill, and another one called iRoot. And again, the manufacturers are ganging up on us and making our life difficult because all of those are exactly the same material. So when you look through the literature and you read the rave results about iRoot and the rave results about this and the rave results about that, you are actually reading all about the same materials. And that makes life a bit tricky. Sometimes they call these things bioceramic root repair materials, or BCRRM. And there are authors around who absolutely hate that term because the materials aren't strictly ceramics and they aren't strictly bioactive either. So this is manufacturer's terminology, which is again muddying the waters rather when we try to describe what these materials are and how they work. This is the one that I'm most familiar with, Endosequence BCRRM, which is a putty. That syringe is so small that you could sneeze and it would fall off the bench. Inside it is 0.3 of a gram of material. And it's a tricalcium dicalcium silicate with no water but additives. It's a putty. It's very, very easy to handle in your root end surgical environment. And at the school, we've adopted it as our direct pulp capping material, just because it's so easy to get onto a pulp exposure and put some material on top of. So this has revolutionized and taken us away from MTA. It's also taken us away from all of those slightly historic calcium hydroxide pulp capping materials all in one move, which has actually been convenient from a teaching point of view. Looking at these materials, I wrote a paper, was involved in a paper in a Turkish dental journal This is the equivalent of the New Zealand Dental Journal in Turkey. And we looked at biodentine, which is a type 4, iRoot BP Plus, which is the one I've just talked about, which is a type 5, and MTA, which is type 1. And when you look at the properties are mainly down to handling. They are these new putties of type 5 relationship. They are very, very good and very, very easy to use. So we've certainly come a long, long way since the early days of MTA. So to conclude, root ends are small, and we've done a lot of work on this at school. Root ends are very small. You don't appreciate it until you're dealing with them. They're difficult to bevel correctly. You can make a beautiful bevel, and in fact, it's an appalling bevel. We can make mistakes with our microscopes. We can not see cracks. We can maybe think cracks are there when they aren't. Our cavities aren't as good as we think they are in terms of depth of preparations and other factors like the smear layer. Smear layer is one of these things we don't understand. But our materials are getting better, much, much better, which is great. So if we can cut a more accurate cavity, clean it better, maybe disinfect it and create an improved seal, our outcomes might be even more favorable than they are now. And we can get outcomes up in the 95s and above with modern periapical surgery, which is really good. Now, if anybody wants to investigate endodontic materials, this fantastic book has come out in the last month, Endodontic Materials in Clinical Practice, edited by Josette Camilleri, and it really is very, very good. It's a long time overdue that Endo had a materials book all to itself. And one of the chapters is good because it's got my name on it, and I'm very proud of that, although it was a hideous amount of work. But this is a seriously good book if you want to know a bit about endo materials. So I'm going to stop now because I know that everybody is going to want to stay and be involved in the AGM. So I was asked to talk for 45 minutes. I've been a bit less than that. So thank you all very much for listening. Thank you.
Thank you.
Thanks, Nick. That was a great presentation. So if anybody has a question or so, Nick's willing to answer a question or two.
Yep.
So I've got one, Nick.
Yep.
I've recently seen that cases have that have been resected, filled with MTA, and the MTA after 5 or 6 years have resorbed away. Any comments? Have you heard anything? Have you seen any research based on that?
So you've opened up the cavity and found the MTA is gone?
Yes.
Wow, that's unusual. Does anybody else have any bright ideas on that one? What I need...
Because I wonder whether these are the MTAs that were placed and they didn't set properly to begin with. And I think that's a problem that happens when you have MTA that sits in a bottle and it gets opened up by the DAs and gets closed and what have you. And it becomes it is hygroscopic, so it absorbs water. And when they're putting it in, it actually probably stays as a mush and eventually just gets taken away rather than setting. Perhaps, maybe.
We had a case at the school under sedation, and we opened the MTA and it was obviously bad once we'd put some in the cavity. So we ran away and we got another MTA of a different kind from another bottle, and we filled the remainder of the cavity with that MTA, and we got a good result. But according to the materials books, that's the last thing we should ever have thought of.
Yeah. Okay.
Yeah, I mean, it does have a limited shelf life. The original MTAs, there's no doubt about that. That when they were doing the research on them, in London in the early 90s, they were making honey pot jars, the plastic honey pots full of the material. And they were going around with honey jars of the material and thinking how wonderful it was, but it was only a few months before it was absolutely unusable.